Our next speaker, Professor Yasser Rifai, is going to talk about the Wavefront guided PRK in mild and moderate keratoconus.
Assalamu alaikum. So I have no financial interest in this presentation. In keratoconus we have two issues. The first issue is to stop the progression of the cone, and this is the cross-linking treatment, and avoiding rabbit. But the patient, after that, they say yes, it's okay, it's stable, but I have no improvement of vision. So the first line treatment is contactology, as said by the speaker before me. Rigid gas permeable contact lenses or scleral lenses, mini scleral lenses. There are some cases that there is no tolerance for this kind of treatment. Now what I will speak about is one of the ways to rehabilitate vision in patients with keratoconus. So PRK, surface ablation, it will be associated to cross-linking, maybe the same time, maybe in different times. So we have to know what is our goal and what is our enemy. PRK is used in refractive surgery. Why? To treat ametropia. Is it our topic now to treat ametropia in keratoconus? No, because our problem is the patient cannot see well with his glasses, and we will try to help them to see better with glasses. So it is not the same goal like in ametropia. So when we see the optical aberrations, we have the level of low order aberrations, defocus and astigmatism. Astigmatism, which is a low order aberrations, it is not our goal. The astigmatism is not our goal because we can fix it with contact glass, with glasses or other treatments. But our enemy is high order aberration that we cannot treat with glasses. Coma, trefoil, and high speaker aberration and others. So the goals are reducing the high order aberrations, improvement of visual acuity, improvement of visual quality. Sometimes the patient had 0.8, but the quality is bad. It has glare, and after the treatment we can reduce this glare. And reducing the dependence of rigid contact lens. We don't say that PRK will replace contact lens. No, it will reduce the usage of this treatment. To improve results of other surgeries, we can do it after cross-linking. We can do it to enhance the results of intracorneal rings, and after phakic IOLs. So the objective, the goal is not to get rid of glasses, but to help the patient to see with glasses. Where are the indications? Preferable a stable keratoconus. The pachymetry should be more than 450, depends, 150, 40, it depends on the tissue that will be removed. The keratometry should be less than 55, but these numbers, it's not approximate, you can play with it. The asymmetry between 2 points in the central circle of 5 mm, less than 10 dioptries, and it should be a question patient. A patient that you ask the patient, do you see well with your glasses? He say yes. Stop. Don't tell him about PRK. PRK is a treatment to enhance the quality of vision. In patient selection, in addition to clinical, to topographic elements and all organic and anatomic elements, carefully study the psychological profile of the patients, because the patients sometimes they not understand what you are doing. They think that it is a PRK like LASIK, like to get rid of glasses, and we have to explain to them you have a disease. It's not a virgin eye. You have a disease, and you are just doing therapeutic refractive surgery and not refractive surgery like in ametropia. So, patient and demanding, understand the principle, and avoid this patient like this with the psychological troubles, patients arguing and asking a lot of questions. It's better to avoid these profiles because we'll have problem with them. You have to be sure that your patient has understand what you tell him. So the technique should be always transepithelial PRK. So now transepithelial PRK in some devices it's like commercial. Non-touch refractive surgery, like free from glass for the first day. In ametropia is the same. Removing epithelium with scarificator or with the laser is the same because the epithelium is irregular. But here, when, as we said yesterday, when we have an irregular stroma, we have an irregular epithelium. So your wavefront measurements have been done over the epithelium, over the tear layer. And when you remove manually the epithelium, you will change the hygrometry of the anterior surface of the stroma. So you have measured the refraction, the hygrometry or the wavefront from the epithelium layer. You have to treat this hygrometry. That's why it should be transepithelial and not other technique. Though this coming from what we said yesterday, the irregularity of it. So the technique is very simple, it's no touch technique. You have, I think that all devices can do it. You can do it in one time, like in Schwinn, or in 2 times PTK and the treatment of the stroma in the second time, it's the same. So the timing of cross-linking, it's a controversial. You can do it in the same time, in a different time. It means you can do a cross-linking, wait for some months, 3, 4, 6 months, then check and do the PRK. This is cool. But you have to do 2 procedures, 2 pains, and you can do it in the same session. So you have these 2 schools, you can follow each. In every school we have advantages and disadvantages. I perform both techniques. If the patients come with cross-linking done in the last 6 years, I don't redo cross-linking and they do PRK. If the patient come without cross-linking, I do the 2 procedures in the same time. So the ablation profile tend to flatten the steep area and to steep the flatten area. We will see here some profiles. It's different from the profile that we see in ametropia. It's not regular, but it is irregular. It's the same shape like of the keratoconus shape. But you will see here a peripheral ablation. This peripheral ablation it helps to stiffen this side. We flatten this side and we stiffen this side to make the cornea more regular. Excuse me, 1 minute. So we have other profiles. It's always irregular. The results you can see in topographic result. We have before and after, and you see that it is early and moderate keratoconus, not advanced keratoconus. But the visual acuity and quality is getting better and better. Another case, you see the cone. We have still a keratoconus after, but with low high order aberration, with a low rate of high order aberration. Another case here. This is a 3-dimensional that shows the cone before the PRK and the cone after the PRK. In conclusion, for me, it's the first line treatment in a keratoconus patient wishing to improve his vision and who is refusing the contact lens. I say refusing contact lens or with contact lens problems. It's precise and long-lasting results. Thank you for your attention.
Thank you, Professor Yasser. One question, please. What is the minimal thickness you leave the cornea after the PRK?
400 or 390.
You remove up to 50 or 60 microns of the cornea.
50 and 60. Maybe, but sometimes it depends. I cannot go more than 60.
What about the incidence of haze post-operative in these cases?
I didn't notice any difference between cases of only cross-linking. I didn't do any study with the measurement of the haze, but I do a lot of cross-linking and combined treatments. I didn't notice any difference. I had now more haze after PRK, after cross-linking, these 3 last year, because I started steroids from the first time.
One question, please. Do you have another post-operative regimen for treatment for PRK with cross-linking different from the cross-linking alone?
No, maybe it should be, but I have no different regimens.
So, you said you will do PRK only in patients who are stable, and your definition of stable is what?
Not stable. I do only PRK when patients that have undergone cross-linking before. Even if the patient is stable, I will do cross-linking with PRK in the same time. But if the patient had cross-linking before, I do only PRK. It means the patient has done cross-linking last year. This time I will do only PRK. But if he is 40 and he is stable and he has never had cross-linking, I will do both PRK and cross-linking at the same time.
Other question? About the direction of using the PRK, you're using the topo-guided or the wavefront, right?
Yes, good question.
The second point before going. The second point, when you consider the high order aberration more than the low order aberration, or both of them, or which one is more priority to the other?
So I use in this device, what we have now is a device that it treats total aberrations. It means corneal and internal aberrations. It is not the best thing, because we will have in 2 months another device that treats only topographic. If you have the choice, maybe I think that you will, because we are treating the cornea, it's better to treat the corneal wavefront. In this device, what do? I measure the whole aberrations, and when I enter the refraction, I enter 0. So I don't treat the ametropy, only the high order aberrations. For the second, between high order and low order, I fix the high order aberrations. And if I have to treat 30 microns and I have more tissue that I can eat, so I can add 1 diopter or 1 diopter and a half. But the priority is for high order aberrations.
Thank you so much.
I have a question for Dr. Yasser. If you receive a patient who's treated by another doctor and you haven't an idea about the depth of beginning of demarcation line, how to manage this situation? Or if you have no sitting with linear demarcation line who is not deeper, how to manage this situation?
So, I think
do you retreat cross-linking and sequential procedure?
The demarcation line is not mandatory in cross-linking. We're not obliged to have a cross-link demarcation line. So I see the report of the first surgery. If it is a good cross-linking epi off, I go for PRK low. If it is epi on, maybe there is a doubt, I will redo cross-linking. But I do not relate my treatment to the demarcation line, because it's not mandatory.
Yeah, okay. Would you measure? Yeah, okay. Do you measure the corneal biomechanical properties before going in such patients?
I have not the device I ordered for this device 2 years ago, and it still not have it now. But I will do it when I receive it.
Okay. Thank you.
If you have bone thickness more than 500 micrometers,
you can correct more myopia or astigmatism with high order aberrations or not?
If you
The
have
thickness of the cornea is more than
500.
much thickness more than 500, and
Yes.
the case early keratoconus.
Yes?
You can correct the myopia or astigmatism
No, astigmatism.
in addition to the high order aberration.
It depends on the refraction, it depends on the vision. I mean, if it's just an early keratoconus, and we have myopia of -5, why trace -5 with examiner? I can reshape the cornea and then go for phakic IOL. So I try to prevent corneal or tissue consuming. The corneal tissue in keratoconus is very precious. So I will ablate the minimum.
Thank you so much.
Thank you.
Thank you, Dr. Yasser. And I have the honor to introduce Professor Doa. He's going to talk